All right, it's 9:30, and we'll get started here. Thank you all for coming. I'm Evan Ross. I'm one of the cardiologists here at Access. And you can see on the shared screen, they're getting ready in the operating room right now. Patients anesthetized, and they're going to start getting access. We're recording the Zoom meeting as well, so we can refer to this video later. And we really want to open up everything for discussion. If you have questions during the procedure, feel free to either pop them into the chat or even say things out loud. We'll all have headphones in and be able to answer questions you guys have. Made a quick little overview of the plan for today. So I will share my screen here. Maybe. Having a little trouble moving things along on this guy. One sec. There we go. All right. So today we're doing a left atrial decompression on a 13-year-old male castrated Yorkie mix who weighs 4.7 kilograms. Originally was diagnosed with left heart failure, left side congestive heart failure, pulmonary edema in March of 2025, and is required up titrating doses of Lasix. He's on a total of just over 10 mg per kg per day. Also on pemobendin and RAS inhibition and amlodipine, and he's mildly azotemic on blood work. So just thinking kind of our approach to left atrial decompression, it's similar to what's been described by the VCA West LA group, but we start having the conversation with owners, both with rapidly progressing left-sided heart failure as well as refractory left-sided heart failure. So dogs that are challenging to stabilize initially with diuretics, as well as ones who are requiring high doses of diuretics. Concurrent azotemia is another consideration, as those dogs may not tolerate increases in their diuretic dosing over a longer period of time. It's also, we'll consider with left atrial rupture, given the potential for reducing the risks of recurrent rupture. And then we do screen all dogs for both TEER as well as open heart surgery, and have the really honest conversation with owners about the costs and benefits. And LAD is a recommendation if those two other options aren't suitable for those patients. And then we want to make sure that dogs don't have a high risk of developing right-sided heart failure post-op, as well as concurrent pulmonary hypertension. Just looking at preoperative diagnosis, diagnostics for our patient. You can see pre-op echo, just going through. I think this is Dr. Cole's primary patient, but there was a conversation with the owners about, I don't think open heart surgery for the patient was a real consideration. TEER was discussed, but I think just look at the wide coaptation gap and pretty severe posterior prolapse made it a little bit less suitable for TEER as a consideration. Going through our plan for today, we'll have patient for LAD, we'll get right jugular access, and we'll do a right heart catheterization. They're starting their access right now. And then we'll use exchange an ancel sheath in the caudal vena cava. Really, the size of the sheath is guided by what size cutting balloon, as well as size of the patient. So for smaller dogs, getting a 6 French is ideal, and you'll be able to use a 6 millimeter cutting balloon, and then higher or larger cutting balloons require a 7 French ancel system. And then following the cutting balloon, we'll do a conventional balloon somewhere between 8 to 12 millimeters, depending on patient size and severity of their disease. I have a little video attached, and we'll walk through how we bend the needle. I think that's often a question that people have, but you can see basically our standard will be to make 2 bends at the tip. The broken bra pediatric needle was standard, the pediatric broken bra needle. Those went on back order. They may be available from another company now, but we are now using a medical stainless steel wire that's cut to 57.1 centimeters. It's 22.5 inches, which works really well. It's very, very bendable, and it's very stiff and allows for pretty good handling. And you'll see the system that we use. It's just an alternative to it, very inexpensive, and we can provide that information as well. And then once the dilator is bent, so the needle is advanced in the dilator of the ansel, it's then advanced into the sheath. And then here, what'll happen is when you advance the dilator into the sheath, it loses that initial bend. So then we bend it a second time in the sheath that you can see that Dr. Cole is doing here. So that is the approach that we have to try to maintain the best bend possible. And we'll go through that in the procedure today. And then once you advance it, you don't click it into place, the dilator, just because you'll need to retract it once you're in the left atrium. Then for the transeptal puncture, just playing through, you'll advance the dilator with the needle not extruded into the caudal vena cava. You'll retract slowly, kind of watching fluoro at this point, making sure once we're in the right atrium, right about here, your eyes will then direct towards the transesophageal echo. This is what they'll call the Phipps view. So it's basically en face of the interatrial septum. Once you're in the right atrium, we'll start doing a clockwise rotation, moving the needle more ventral, and you'll see the tip start to come into contact with the fossa, retract slowly, sorry. And you'll see, with gentle advancement right there, you'll see that we've made our puncture, and then we advance the sheath through the puncture site, removing the dilator and needle in combination. In general, you don't need to expose the needle. We haven't really had to at all, but that's one consideration with really, really stiff fossas. And we'll go through that in real time today. And then you'll usually see bubbles in the left atrium on TEE and also be able to visualize it. And then this is when we'll get LA pressures with the ansel in the left atrium. And then we'll do a cutting balloon dilation over an 018 guide wire, which is then followed by a conventional balloon dilation over an 015 guide wire. And then we'll get LA and RA pressures post-puncture and recover the patient. There's complications have been outlined before, but a pericardial fusion, we do heparinize the patients after the puncture, making sure there's no pericardial fusion. Right to left shunting, something that we've seen, especially in dogs with concurrent PH, and it's really goes into your preoperative evaluation. Dogs will have arrhythmias invariably. Some dogs do go into atrial fibrillation and require cardioversion. Generally, they do respond well, and sometimes just a dose of lidocaine with acute AFib helps with conversion. And then a non-ideal puncture site. So if you don't puncture the fossa, you'll be worried about closure post-operatively. And sometimes we do make a second puncture if we don't like our puncture site. And then in terms of recovery, here's just a look at a dog with an LAD. This is probably about 6 months post-op. We'll keep them on Plavix for 3 months post-operatively. They'll go on PD5 inhibition. It's basically standard of care for us now, about 2 mg per kg sildenafil. We started just twice a day dosing. We can go to the 3 times a day dosing if there's more concerns for pH. And sometimes we'll dose reduce the Lasix, and then we see the dogs back in a week. So that's our overview for today in terms of procedure. I'm going to hand the reins over to Dr. Zarin, who's doing transesophageal echo. He'll walk through some of the images as well as our anesthetic plan, and then we'll move forward with the procedure.
All right. I hope everyone can see my screen. If you can't, just let me know. Oh, dear Lord. All right, there we go. So I'm going to just try to run through the LED imaging just really quickly. Just a real quick shout out to the probe covers. These really help maintain contact, which ends up being one of the biggest limiting steps for TE. So I just included this with some reference and ordering numbers. In terms of probe positioning, it's pretty simple. We just want the mid-esophageal position for the TE. We get the 4-chamber view. I find that the phase array angle needs to be, technically it's supposed to be 0 degrees, but I find that it's plus or minus 30 degrees, even sometimes plus or minus 50 degrees. If On the GE machine, you do have to, there's no negative degrees, so you have to go like plus 130, plus 150, and then do the left right switch. As you see on this image that I have right here, the beams on this side, this could be left righted it. And then typically for the LEDs, I actually think that the acoustic window is the most important thing rather than perfect positioning. So I try not to get too hung up on like, is it a perfect four chamber view? Is it a perfect table view? Because the 4D image ends up being sufficient as long as you have an acoustic window. When I'm doing an initial assessment of the heart from the CE standpoint, I'm comparing the LA side or LA sides, LA or LA to LV in comparison to the RA and RV. That way, when we're doing the puncture and post balloon, you can actually see the right side get bigger, and that we're still trying to figure out how that changes our decision making in the operating room. But it's something for me that I like to see because if the right side gets massively bigger after the cutting balloon or even a small balloon, then I think I would lean less likely towards not continuing to balloon further. I also look at normal things like mitral valve morphology, color profiles of the MR, inflows, same thing with the tricuspid valve. I do like to assess for preoperative or at least pre-balloon pericardial effusion. That way, if we do get it post-puncture, we know that it's new. I also look for pre-existing ASDs, which does happen. You don't want to try to make a ASD when there's already one there. And then if you have extra time, you can look for the on-FOS view of the mitral valve in 4D for potential tier candidates, AI, PI, PDAs, all those fun stuff to look for. Just a little heads up, this is the cable view. We have the left atrium on top. We have the right atrium to the bottom right. The caudal vena cava is coming out to the left. The coronary sinus is also in that area. And then the RV is down there with the tricuspid valve there. And this is the patient with the puncture already there. So you can see the ASD between the left atrium and the right atrium. Another helpful view for this is a short axis phasal review. From the four chamber view, all you have to do is do a hard antiflex, and then it'll usually put you right there at the level of the aortic valve in short axis. In terms of image acquisition from the four chamber view, this is how you can get the 4D image. To me, one of the biggest really helpful for me is to realize that the point of the 4D zoom preparation step is only to choose the sector size and to confirm the appropriate probe position, but it doesn't really do anything else. And so when you're determining the borders, usually I make it as wide as possible. This starts with the 2D width, and then you can make the sector really, really wide. You want it to be as tall as possible so you don't cut out any septum, but I usually leave out this little Hershey's Kiss of near field artifact. That way it doesn't show up on the 4D image. And then the lower borders are just below the AED valve. You really don't need any ventricular information, so I try to cut that out as much as possible. And then if you want to see if you're in the right position, if you throw this cursor through the tricuspid valve, usually right in the middle of it, you'll get a cable view on the biplane. And then that can help you determine if the probe is too cranial or too caudal within the dog. And you can determine that by if you can see the caudal vena cava and a little bit of where the cranial vena cava will be coming out. And as long as you see something like this, generally you're in a good spot. And so this is a recording of me getting this 4-chamber view, and then you end up with this 4D image. And I call it a cable-ish view. It's not really a cable view. In terms of orientation for the images, this is the FIPS view, as Evan pointed out. The aorta is going to be facing cranially to the left. The mitral valve is over here on the bottom, which is ventral. Caudal is over here to the right of the image. The interatrial septum is here, and the right side's on the other, right atrium is on the other side of the septum. Then dorsal is obviously up. When I'm trying to optimize the image, the things that I remind myself are, you don't actually need the entire mitral valve annulus. So I'll do a full a clockwise rotation of the probe to the right side of the dog. That way you only get the right side of the annulus, and you get way more septum. And then I always keep the aorta in view. That way you can see where the needle is in relation to that, because we don't want to do decompression of the aorta. I call these clouds. You can get rid of some clouds by adjusting the gains. You can also translation. You can do a 2-click crop if you really want to get specific. And then one of the most important parts during the procedure is identifying the poke zone with the primary operator, that we're both on the same page when we have the needle in the dog and we're trying to do a puncture. So if it's too ventral to dorsal, we're on the same page with what our directions are. And then I think Evan actually showed a really nice image of the puncture, but this is just a quick little what it looks like when the needle actually goes through the septum. It can be subtle sometimes, but for the most part, we can see that. After we puncture, this is when we go back to 2D. We see if the catheter is visible in the left atrium. We also like to see if there are bubbles present in the left atrium following the catheter flush. There are times when the catheter actually goes like in the coronary sinus region, and it seems like it's in the left atrium, and then we flush and then no bubbles show up. So that's a really nice helpful way to see that the catheter is actually in the left side. And then one of the biggest steps to look for to do is pericardial effusion. I tend to just zoom out and then just rotate the phase array angle 360 degrees, as opposed to moving the probe all over the place, so you don't lose your position and don't mess with your contact. And then pre-balloon 2D imaging. For me, the goal is to determine if the balloon is crossing the septum when it's inflated. With the cutting balloon, it's much harder because the balloon can be really, really short in comparison to the dog's size. Fluoro isn't super specific with this. And then the long axis views, in my opinion, are really hard to interpret. So I try to get short axis images in order to determine this. So what I do is I get a 4-chamber view with the catheter and a short axis, and you can see that here, this little circle. That's right next to the septum. I move the probe just caudal, aka into the dog, to where that catheter actually crosses the intra-atrial septum. And then what I do is I choose a multidimensional option called V-plane. And you guys might be asking, well, what the heck is V-plane? V-plane's a really cool option, at least on the GE machines, that allows you to basically span the sector in a cranial or caudal direction, or even lateral if your initial plane is lateral. But so if you imagine that the initial image that we get is kind of this 90-degree angle to the foot of the probe, you can V-plane or fan the image cranially to get a second image. And what this allows us to do is we get the initial image that we got with the catheter crossing into the left atrium. And then if we fan cranially or V-plane cranially, we can actually see where the catheter is crossing into the right side of the heart. And that way, when we balloon, what we get are 2 simultaneous images, with one showing the balloon inflated in the left atrium. And this is contiguous to the lumen, and you can see it next to the mitral valve, and you can say for certain this balloon is on the left side of the septum. And then on this image, again, this is just fanned 15 degrees cranially, and this balloon is on the right side of the intra-atrial septum, and we can confirm that this balloon is in fact across the septum. And then when they're ballooning, I'll usually say you're left and right, or you're left, you're not right, and that way the operators know where we are with everything. And then after the balloon, you can assess a few things. So again, the left-sided chamber sizes versus the right-sided chamber sizes. You can look at the defect in multiple planes. You can get color, pulse wave, continuous wave, and then you can get 4D image of the defect, and then tricuspid valve pressure gradients as well. And then you get something that looks like this, and then we're all very happy, and we close up shop. This is it in 4D. I think that's all I had to say. So I don't know if anyone has any questions, but I do think that we are ready for next steps of the procedure.
All right, so during the first part of the presentation, we got access with a short introducer in the jugular vein. We're using a 6 French sheath, and we're just going to do a right heart study. So we already have our glide caths in the pulmonary artery. And, this is actually less pulmonary hypertension than we typically see with some of our cases. So we actually feel pretty good about that. Just for orientation on the monitor, ECG, pulse ox, CO2, the yellow trace is going to be measuring the right heart pressures, and then we're going to use that again when we get into the left heart. And then we have an arterial catheter in the dorsal pedal artery. Sometimes the fluor doesn't show up beautifully on this, but we're now in the right ventricle. And once that settles out, we just get a baseline right atrial pressure. So we're starting out with a right atrial pressure of 7, and that can also be influenced by the height of the transducer, of course. So what I normally try and do is to speed up the procedure, we'll just use the catheter to get out into the caudal cava. You just get past the intravenous tubercle, and you can flip the catheter around and direct it caudally. And now what we're going to end up doing is an exchange of the introducer for a check flow introducer. And Ivan, if you just want to zoom in a little bit. Yeah. Yeah, a little bit more. And then this way. Perfect. Beautiful. Thank you. All right. All right, Katie. Catheter. Okay. And I guess a little trick for this is, I'm not sure if you can see this, but when we make initial access, rather than suturing the short introducer in place, we just use some hemostats to clamp it to the drape just because it's only going to be in for a few minutes. So remove the hemostat. Good. Great. So we're also going to use a 6 French check flow introducer for this dog. He's on the smaller side, and we'll use a smaller cutting balloon. So the 6 French check flows will accept a 5mm and a 6mm cutting balloon, whereas the 7 French, you can get a 7mm and an 8mm cutting balloon. So I'll just park this in the caudal cava. Come on out. All right, the next part, let's do that over here. So we initially started doing this procedure with pediatric rocket round needles. The only manufacturer was Boston Scientific, and then they stopped making the needles. And so we didn't have a big back stock, and we were kind of forced to improvise a little bit. And so actually got an email yesterday that there's now a new veterinary pediatric transeptal needle available. And so I'm very enthusiastic about giving those a go. But in the meantime, we use 038 stainless steel wire as a stylet. And so one of the nice things about this is that as opposed to the pediatric Brocken-Brown needles, there's no taper in terms of the gauge of the needle towards the end. And then we have, kind of ultimate flexibility about how to bend the needle. Sometimes with those pediatric needles, if you're trying to get the bend at the step and gauge, which is right towards the tip of the needle, it can fracture. And so this kind of avoids that. So what we end up doing is inserting the stylet into the dilator. And then we'll make a 90-degree bend. And just use this for directional control. Next thing that we'll do is we'll make an initial bend at the tip of the dilator. And, there's really no science to this. It's a little bit of an art. We've sometimes used 2 bends in smaller patients. A lot of times we'll just use 1. What we end up doing is anytime you put either the transeptal needle or the stylet through the check flow, this plastic portion will unbend your bend. And so what we end up doing is actually rebending the stylet inside the sheath prior to introducing it into the dog. So we'll go ahead and do that now. Yeah. Yeah, so the bend, I'm not sure if this shows up. Get some light behind it. So this is what we're going to start with. And so the initial bend is about 1 centimeter from the tip, and then we have just a minor secondary bend about 1 centimeter proximal to that. Thank you, Ivan. Okay. And so we will go ahead and introduce the stylet. The sheath that we use, the T-port is 180 degrees opposite the bend of the sheath. And so when we have it oriented this way, it's actually pointed dorsally in the dog. All right. Ivan, can you zoom a little bit up here? Perfect. All right. So now we have our bend, and so that bend has been unbent, for lack of a better word, by inserting it through the top of the sheath. And so we're just going to reform that bend. All right, and this more closely approximates what we had before. All right, so at this point, we're just going to check and make sure that our visualization is good. On the 3D echo image, you can see the sheath on the far side of the septum. I do think that our fossa is just beneath the sheath right there. And we'll actually be able to see that better as we're advancing the needle. All right, let's go ahead and go in. Perfect, thanks, Katie. Okay. All right, so normally what I'll do is I'll park the tip of the stylet there. And at this point, we'll just go ahead and retract the sheath. It's in the caudal vena cava. Just a small point, I typically don't lock the dilator into the sheath. It just makes it a lot easier to advance the sheath off of the dilator once we make our puncture. All right, JZ, you ready?
Mm-hmm.
All right. The steps here will be, we will withdraw the needle into the atrium. And then I'm going to actually clock the handle. And I'm going to hold both the stylet as well as the T-port at the same time. And I'm going to clock that this way. So we're pointed dorsally, and then we're going to end up leftward. The dog is in right lateral incumbency. All right, coming back. Okay, now we're going to go ahead and rotate. You can actually see the tip of the needle. It's a little bit low. I'm going to retract cranially. I feel like that's about where the fossa is. A little more cranial, and then we'll just gently advance. Below.
There you go. Right.
It's supposed to dive neutral. We may not have quite enough bend.
Yeah. You're in the right spot.
Yeah, I know it. That's too cranial.
Too cranial, too cranial.
All right, I'm going to rebend.
Okay.
All right, so we will re-bend this. See if we can get the sheet across the bottom. All right. We can get the guide wire and Berenstein again. Yeah, I think so. Any questions? This is a good time to ask. That's good. Okay.
Hey Steve, it's Bree. Just a question about in any of those attempts, did you extrude the stylet or just if you're not liking, yeah.
Yeah, that's a good question. I mean, we have rarely, if ever, had to actually extrude the stylet. I can show this in a minute. We put a little bumper on the end of the dilator that if we wanted to extrude it, I could just essentially unscrew that. And then we've got a couple of millimeters out the end of the dilator. But we have not had to do that. So typically, we were in a good spot. And I think that our issue was primarily just not quite enough bend to engage the fossa. So I just wanted to slip. So we'll see. We'll kind of rebend it a little bit more acute of an angle. And my feeling is we shouldn't have too much of a problem. The visualization, as per usual with Dr. Zarin, is excellent. So I think we should be set up for success. Okay, let's go ahead and advance the guide wire. Perfect, thank you. All right. Just to illustrate that, Bree, so here we go. This little red cap comes with our with our transpacts for monitoring. And so we just screw this onto the end of the dilator. If I ever needed to extrude the needle, I would just unscrew this, kind of bend it past here, which I'm making look harder than it is. And now when we advance this, we get a couple of millimeters. And so I'm not sure. Ivan, can you zoom? And so now that we've done this, we have like 3 millimeters of stylet passed. And so these are blunt, but certainly I think that's probably plenty to cross most septums. And if we ever had to electrify the needle, we could do that as well. Right, so back here. All right, so we'll go ahead and I'll just rebend out here. Ready? Right. And then reform that bend in the sheet. So that looks a little bit more like it. Thank you, Katie. Right. We'll give it another go.
Ready.
All right, and once I'm atrial, we'll start rotating. You can see the tip of the catheter right there at about 3 o'clock on our image. All right, so I kind of like that. I usually come slightly cranially, and then we can advance from there. And now we're through. And so with our left hand, we'll just advance the sheath, and we're atrial.
Awesome.
We've got a really nice picture right now on our echo image of the sheath crossing the septum. So we'll go ahead and get some left atrial pressures.
And we're
Nadine?
negative for pericardial effusion.
That's an excellent point. So we typically, after we make the puncture, we'll assess for pericardial effusion. And then assuming we don't have any, which is quite rare to have any, we'll give 50 units per kilo of heparin. Nadine, you can flush to me. All right, perfect. And let me just get a syringe. Another point is a lot of times the needle will actually entrain some air. And so rather than just flushing the sheath after we get in, we'll just aspirate. All right, go ahead and flush to me, Nadine. Perfect, thank you. And to see a small amount of bubbles is typical.
And then on my end, what I'm doing is on the left image, you can see that the catheter is crossing into the left atrium. On the right image, you can see that the catheter is just in the right atrium, but along that interatrial septum. So that when the balloon should be right there. And so when you see the inflation, you'll actually see that the balloon's on either side.
And then this dog actually has fairly well-controlled failure. He's a little bit dry this morning. And if you look at our left atrial pressure, it's actually relatively normal. We typically will see much higher left atrial pressures and really profound V waves, sometimes actually reaching systemic pressures. So we're starting off with a mean of 13. And so it'll be interesting to see what happens after we balloon it. We don't need to be particularly aggressive with this patient. So that will also influence our decision about what size conventional balloon to use. We're going to use a 6 millimeter cutting balloon in this case because we have a 6 French sheath. Prepped? Okay. All right, Amy, back up just a touch. Perfect. Yeah. All right, with me. Let's advance the guide wire just a couple of centimeters. Perfect. Okay. And so trying to estimate where the septum actually is, most of the time it's going to be kind of mid cardiac silhouette. And we will then adjust our placement based upon what we're seeing on that. The guide wire that we're using is what's called a 3-way guide wire. There's another model called a high torque guide wire, very similar. They are 0.018 guide wires with a very stiff shaft and then a very flexible tip. So they're great for stabilizing the balloons. All right, so that's about where the septum typically will be for most of our patients. And so the cutting balloon, which is delineated by the markers, is inside the sheath. I'm just going to hold this here. We're going to advance the guide wire, see if we can get it to fold over in the pulmonary vein. Perfect. That's fine, Katie. And so then we're going to withdraw the check flow while stabilizing the cutting balloon. And we're going to go ahead and make our first inflation right here. Going up. Let me back out. Perfect. Going up. All right. And so as Dr. Zarin had shown previously, we can see that on the left-hand panel, we've got cutting balloon in the left atrium. And on the right-hand panel, we have cutting balloon in the right atrium. So we know that we're transseptal. There's also a tactile verification. So you can feel that with your left hand as you're stabilizing the catheter. Typically, we'll leave the balloon up for about 45 seconds per inflation. We'll do 3 inflations with the cutting balloon. and then 3 inflations with the conventional balloon if we decide that we need that as well.
Just a little tidbit. I think this is probably the more intuitive way to do it, where you have it in long axis in at least one view. In my opinion, it's very hard to get a reliable image to say if that balloon is actually across that septum or is it just lying along that septum. And so that's when we developed the V-plane method, where you can clearly see that the balloon is on the left side in the left atrium, and we can clearly see that it's in the right atrium simultaneously.
All right, Evan. That's good. And then typically here, I'll just kind of reposition just a little bit, and then we'll reinflate. There we go. Perfect.
It might be a little too right.
Yeah, I see that. All right, looks like we're
There you
a
go.
little bit more left.
Yeah.
Perfect. It's a nice picture.
More pretty than it is useful.
All right, we can come down. Looks good. Let's reposition. All right, going up. Looks good. All right, we'll measure and take a look at the defect, and then we can decide. Okay, let's come on down. Katie, if you want to just give me some negative pressure here. And then we will just re-advance the sheet over the balloon into the left atrium, and then withdraw the cutting bolt. Just get a syringe real quick. Same thing, so we sometimes will entrain some air, so I will always aspirate prior to flushing. Go ahead and flush to me. Thanks, Nadine, that's perfect. So not a ton of change in our left atrial pressure. Our V wave's a little bit blunted compared to what it was before. I don't think we have a huge defect. You can see on the TEE that we've got just a little pericatheter flow. And so certainly we would expect more without the catheter there, but I think it's reasonable to use a conventional balloon here. All right, so we've got the safety J. Let's go with a 9. Perfect. Thank you, Ivan. Burst pressure is 12, nominal 7. This just going to take a second to prep this balloon. Another good time to, if there's any question. All right. Go ahead and do that. Perfect, Katie. Yep. All right, come with me. All right, beautiful. Go ahead and advance the guide wire from there. See if it'll park like it. Okay. All right. Just going to back off the sheath. We have a pretty good idea of where that septum is. With the conventional balloons, a lot of times we actually get a little bit of a waste as opposed to the cutting balloon. So just can verify visually in addition with the TE. All right, go ahead up. Yep. We're all right. All right, come on down a little bit.
You're creeping in the left.
All right, that looks good there. Go ahead up.
There you go.
Yeah.
Good.
All right.
No. I know it's crazy, but I think you might be all right.
Yeah, just I was grabbing a gauze. All right, come on down, Evan. We're gonna be fine there. Yeah, going up.
Perfect.
Yeah, better. Okay. Haven't done a number of these. I would say that the operator part is actually maybe 20% of the entire procedure, and imaging is 80%. So today is a really good example of how well you can see things, and how important it is to guide the procedure. All right, that's 45. Come on down. Great. I'm going to just reposition. All right, going up. Perfect. Thanks, man. Looks good. Another 10 seconds, we'll come on down. All right, come on down. Perfect. All right, Katie, you can give me some negative pressure with that. What's up? You don't want to count the first one? That's all right. We can do this one. One more time. Yeah, go for it. For sure. All right, it's good. We'll just re-advance. Perfect. Re-aspirate. All right, Nadine, flush. Flush to me. Perfect, thank you. All right, so pretty static means our systolic has decreased. I'm not getting a great pressure wave. Do you want to do one more flush, Nadine? Thank you. See if that works out better. There you go. All right. We're going to come back from right to left. Excuse me, left to right. And our right atrial pressure has increased a couple millimeters of mercury from 7 to 10. We still have a little bit of a gradient from left to right. And then we'll reassess the defect, make sure that we're happy. In situations where we feel like we're not in the fossa, or we don't have an acceptable hole, we will repuncture or just try and find the same hole if we think we're in the fossa and just use a larger conventional balloon. But we've got left to right flow throughout the cardiac cycle. And I think that gradient fits with what we measured as well. So feel pretty good about it. Can you just measure it in systole?
Yeah. I'm do it.
Okay.
With different angles.
Yeah, you can also see that there's a little bit of edema of the atrial septum on the left side of the image. We see that from time to time, and typically at recheck that will have resolved. And oftentimes the defect actually measures bigger after that. I think we're good, JZ?
Yeah, I think we're good.
Okay, perfect. Well, that's pretty much it. All we'll do now is take out the check flow. We put in a skin suture, hold off for about 15 minutes. Neck wrap, we tend to do these as outpatients. And so with our anesthetic protocol, generally recovery is quite rapid. It's a DIVA protocol. So typically 5 to 10 minutes after the procedure, they're up and around, feeling pretty good and ready to go home the same day. Yeah, we're happy to answer any questions. Other than that, yeah, you want to do that? Okay, perfect. All right, Katie. Let's go ahead and get the 3-aught nylon.
And my
Hi.
apologies. Oh,
Hey.
Oh, sorry. This is Dr. Burberry from CGCF. I was just wondering what your anesthetic protocol is.
yes, actually, if we have time, I'm happy to share that with you. Let me just pull it up.
And then I guess certainly it goes without saying, we wouldn't be doing any of these here in particular without kind of the generosity of Dr. Allen, Dr. Phipps, and everyone at BCA West LA. After Justin started doing the procedure, we had sent a number of patients down to have LADs done just because we had seen how well they had done. And at that point, we hadn't invested in the 3D ultrasound capability and didn't have the 3D transesophageal probe. Got it. And, I can't say enough like how genuinely helpful, excited to share, and certainly how non-proprietary they've been with helping us get started with this procedure. Ready?
Yeah, and just to echo that, this protocol is from them, and their anesthesiologist helped develop it. So we're just riding their coattails. But our pre-med plan is pretty simple. You got hydro or any opioid of your choice, midazolam, and the normal things. When we induce with midazolam, ketamine, and etomidate. Fluid rates are pretty standard. These are all the medications that we pull up, antibiotics, pain medications, heparin, pretty standard stuff as well. I think the most important stuff that we're doing is the CRIs, where we run remifentanil, ketamine, and midazolam as our main maintenance anesthetic. We tend to do KCL for every single patient. Based off the West LA cases, they were having a lot of issues when they didn't have KCL, even if for the normal clinic patients. At least that's what I'm under the impression of. So we run this depending on what their potassium is. We'll go higher if needed. And then we'll run dobutamine and furosemide if needed. Usually we have dobutamine going. And then post-op, we just recover them with buprenorphine for the most part. We'll change these plans per patient if needed, but nothing crazy. And then we have these just in case. We don't pull these up automatically. We just do that if needed, but norepi, dopamine, lidocaine, and propofol. And then our other emergency medications. Are there any?
Thank you.
Cool. And I'm happy to share this document with anybody if anybody wants it, and as well as the imaging presentation for notes.
Yeah, for sure. If there's any other questions, we're happy to answer them. Otherwise, we can end the meeting and everybody can get on with their day.
Yeah, and thank you guys for all coming. We really appreciate it.
Okay, got it.
Cool. Awesome.
All right, got it, Katie? Perfect. All right, let's go ahead and I guess we can end the meeting.
Cool. Thanks, guys. If anyone has any questions, y'all can always send some emails.
Thanks. Thank you.
Of course.
Good job.